Okay, so let's talk about pregnant disorders. This is the second half of the female reproductive system. This what makes the nursing in this field a little bit more challenging than any other subject because it's really dealing with two different things, the non-pregnant state and the pregnant state. So a lot of students, and nurses for that matter, when they're studying for the NCLEX or other exams, find this to be doubly challenging because of that reason. So just giving you a heads up. So I'm going to try and teach you some terminology first, and I'm going to assume that you know a little bit about how the development of the fetus is, an embryo, from your previous anatomy and physiology course that you had before. So without further ado, let's go into it. So let's first talk about, very briefly, about terminology that we're using throughout this section of pathophysiology. Contraception. Contraception is just a fancy word for fertilization. This is the time when the egg and the sperm finally meet. Okay, that usually occurs in the fallopian tube, at where the greatest bend is in the fallopian tube, called the ampulla. Okay, so that's where it mostly takes place. We also have the word gestation. You're going to hear that quite often, and that's just a fancy word for saying pregnancy. How many gestations have you had in your lifetime? How many pregnancies have you had in your lifetime? Well, once the conception occurs, that's what it is. We're not talking about how many children, we're talking about how many times you've been pregnant. That includes miscarriages, abortions, and live pregnancies, okay, preterm babies or not. Age of gestation just tells you what at that stage, if a woman is pregnant, how many weeks is she in that pregnancy? Is she 14 weeks? Is she 28 weeks? What's her age of gestation at that time that she is at that moment? So that's what we're talking about, age of the pregnancy, so to say. Okay? Now we're going to talk about trimesters. Now we're in the field of medicine, and since we're talking about OBGYN, we don't talk in layman terminology of how many months you are. That's because each month doesn't have the same amount of weeks. Some might have 4.5 weeks, some might have 3.5 weeks, some might have 5 weeks. So we go by weeks. As the embryo and fetus grow inside the woman, certain events occur at certain number of weeks. If we go by months, we're going to be missing out on certain things, let alone knowing when to do certain tests on the baby or certain procedures that can be done. So, or not the baby, but on the embryo or fetus. So we need to go by weeks of gestation, okay? So we go by trimesters. That means it's every 14 weeks. So adding to a little bit of confusion, if you haven't been in this genre before, when the layman says that there's that she's 9 months pregnant would mean that they're full term. But in actuality, we go by weeks. And we go by first trimester of 1 to 14 weeks, second trimester is 15 to 28 weeks, and third trimester is 29 to 42 weeks. So if you're actually going by months, the months, if you're saying that on average 4 weeks per month, then you're talking about 36 weeks, and that is not a full-term baby. We're going by weeks now. Full term is anywhere from 37 weeks to 42 weeks, okay? On average, we use the date that you are due, like your due date, as week number 40, but you could go 2 weeks over that. After that, we have to induce you, because there are certain things where the baby's at risk of dying. So at 42 weeks, we will induce the labor if they're not in labor already. So full term, as I said, 40 weeks is what we call as the date of delivery, okay? But we can go over 42 weeks. If she starts going into labor at 37 weeks, 38 weeks, 39 weeks, we're not going to stop them because we still believe that she is full term in most conditions. When I say most conditions, if we know for sure when her last menstrual period was, and we know that for a fact, then we could go by 37 to 42 weeks. But a lot of times, women come in and they don't know when the last menstrual period is. And they come to us at, let's say, 24 weeks. It's a little bit too far ahead, but you know, they should know that they were pregnant after 24 weeks. We're looking at almost like a 5-month pregnancy. If they're not too sure of the last menstrual period, then we got to start questioning. Maybe are they really 24 weeks or are they 20 weeks? We don't want to, especially if we get into the later of the due dates. So is she really 40 weeks or is she 36 weeks? That makes a big difference in terms of premature delivery or not, and those lungs might not be mature on the baby. So for the most part, in most conditions, we consider 37 to 42 weeks being a full-term pregnancy, with 40 weeks being the due date, okay? Anything less than 37 weeks, we refer to as preterm. And our biggest concern with that, there's a lot of issues that can happen with preterm deliveries. But one of the biggest ones that we're concerned about, we talked about, was having those lungs not mature, that they're not going to produce surfactant. And that's one of our biggest concerns about that, okay? Post-term is what we consider after 42 weeks. And as I mentioned to you before, in that case, we will induce labor, because by that time, the baby usually has, fetus at that point, but the baby usually has a lot of fluid around him or her, so there's enough cushioning, and the umbilical cord is floating there, so there's no compression going on. But as the weeks continue, up to 42 weeks, there's less and less fluid that's cushioning the baby. So now let's say the umbilical cord is over here, there could be like a slight movement of the baby and compressing that umbilical cord. That umbilical cord is going to carry oxygen, oxygenated blood to the baby, so we don't want to occlude that. So at 42 weeks, our biggest, we need to induce the pregnancy because there is a greater risk of the baby dying. Okay? So the time periods. Now, when we're referring to the fetus or the newborn, if the baby's still in the mom, then we can refer to that as prenatal or antenatal care. Okay? So from conception until the time just before birth, right? Then we refer to that. Postnatal is once the baby is born afterwards. So sometimes we do prenatal care or antenatal care of the baby, and that means we've got to do some kind of procedures, there's some kind of taking care of the baby while inside the mother. We refer to as prenatal or antenatal care. Once the baby's out, then there's what we call postnatal care that we might have to do on the baby, either for breathing or not seeing properly, or which not. So that's what we're referring to. All right, the neonate is the actual name of the boy or the girl, but once the baby comes out, we refer to it as a neonate, not a fetus or an embryo anymore. Referring to the mother, we call antepartum. Antepartum is the time when she is pregnant and it's before childbirth. So we have antepartum care that we might have to take care of. Postpartum is anything that's going to occur after the childbirth. So sometimes we'll have something called postpartum hemorrhage, where once the baby's born, the mom is bleeding excessively because the placenta is left in or whatnot. So that's what we're referring to as antepartum or postpartum. These are words you need to get under your belt, because I know they will use all of these when you get to your med-surg, clinical rotations, let alone the NCLEX. All right, so nomenclature. All right, you're going to see these words quite often again. Gravida is a Latin word for pregnancy, okay? Then we have something called para. Para is Latin for bring forth. So you've been pregnant, how many times, you say how many gravidas you have, or gestations, but in another way we could use, if someone's gravid, they've been pregnant sometime in their lifetime. But then para is Latin to bring forth. So what we're talking about is, okay, of your pregnancies, what were they? Okay, were they miscarriages, were they abortions, were they preterm deliveries, that kind of thing. So prior pregnancies, we call someone nulla gravida or nulla gravid, meaning that this is a woman that's never been pregnant before. Okay? Primigravida is that she is pregnant and it's the first time she's been pregnant. So you'll hear People call this a newly gravid patient or a primate patient. You'll see those abbreviations, but you'll also see these bigger words more or less in your future courses. Multigravid means that they've been pregnant many, many times. That means more than once, actually. But it could mean 28, okay? So that's what that means. And it could be abortions, miscarriages, pregnancies, that kind of thing. Multiparous is that you actually gave birth multiple times. So in a case like this, you could have someone who's multigravid but not multiparous. Here's a woman that's been pregnant 8 times, and of those 8 times, she had 4 miscarriages and she had 4 abortions. So what I'm saying with that is that you haven't really given birth to a live baby. So that's what we say, it's multigravid, but she's not multiparous. If she's multiparous, it means that she's actually given birth to live babies multiple times. Okay? So there's a difference between multigravid and multiparous. Okay, so how do we document all this? Well, there's a, you want to call it medical terminology or medical alphabet, but there's little numbers to help us to distinguish what's going on. It's like a code, but you'll be able to understand this code, and you will need to know this for, like I said, your NCLEX and all your future stuff. So we use the letter G to stand for gravida, like how many times you've been pregnant, G, okay? Then we have the abbreviation P for para. Okay, you've been pregnant 3 times, but of the para, what were the pregnancies? Were they miscarriages, abortions, were they twins? It tells you all about that. So we have this, I have to call this a little mnemonic, but this is the way it is. It's basically how many times you've been pregnant is going to be where the G is, and then we have something called T.P.A.L. And what that stands for is the number of term pregnancies, the number of preterm pregnancies, the number of abortions, and with the abortions, it's also including the miscarriages, okay? And then we want to know how many of the pregnancies are actually living children at this point, okay? So we have this gravida number, and then para, you're going to break it up into 4 digits, okay? And the 4 digits will actually tell you what's going on. So let's do a few of these as examples. You will need to be able to do this on my exam and the future exams that you're going to have for other courses, and also the NCLEX, and if you're going to this field or emergency medicine, you still got to speak this language. Not hard, it's a little bit fun once you get it too, okay? All right, so let's give an example. Gravida 1, para 0. When you have gravida 1, para 0, how many times has she been pregnant? 1. Okay. Now, in a case like this, if she's only been pregnant once, shorthand, and you see this quite often, is that she's only been pregnant once and she hasn't given birth. In other words, she's pregnant right now. That's the only time we really use this abbreviation, that she's pregnant right now, and we use gravida 1, para 0. So she's currently pregnant, but there has been no prior pregnancies or abortions. In this case, as I mentioned before, you can write, and there's nothing wrong with it, you can write, and it's more precise, and you can see what's going on, gravida 1, para 0, 0, 0, actually there should be another one there, 0, there should be 4 zeros, okay, for T.P.A.L, right? That's telling us that she's pregnant right now, but she has not given birth or had a miscarriage before. So usually in a case like this, the only time you usually see it is that usually cuts down to G1, para 0. And we see that quite often, and that just infers that she's pregnant right now and she has no other pregnancies before. Okay? That's a pretty straightforward one. Let's go into something like this. Here's a woman that has G1, P1, 0, 0, 1. Now remember, we're using our mnemonic as T.P.A.L. So this is how many term pregnancies, how many preterm pregnancies, how many abortions, and miscarriages. They're under the same category. And then how many living? Okay? You can do this. Gravida 1, para 1001. How many times has she been pregnant? Forget about this stuff over here. Just look at the G1. How many times has she been pregnant? One time. Okay? Now, of that one time, what is this telling you? What's the first one telling you? That she had a term pregnancy. Right? She had no preterm pregnancies. She had no miscarriages or abortions. And she had one live pregnancy. That live pregnancy came from this one over here. Does that make sense? So here, is she currently pregnant? No, because all the numbers are accounted for. She's gravida 1, she's been pregnant once. That pregnancy was this one here. And it was a live pregnancy. So we say that this is gravida 1, para 1001. She had one full-term birth. Okay, does that make sense? Okay, let's do another one. Gravida 2, para 1001. How many times has she been pregnant? Twice. Okay. Now, let's see what the pregnancies are. She had one full-term pregnancy, no preterm, no miscarriage or abortions, and she had one live birth from this one here. So what else is going on with her? So she has gravida 2, para 1. She's currently pregnant at this point. Does that make sense? Okay, so she's currently pregnant, and she has one full-term baby that was live in the past. Okay? Gravida 2, para 0101. What does that tell us? How many times has she been pregnant? 2 times. One time, did it have a full-term pregnancy? No. Did she have a preterm? Yes. It doesn't tell us how many weeks was the preterm. It could be 20 weeks. It could have been 34 weeks. We just know that she had one preterm delivery. Any miscarriage abortions? No. And she has one live child from that one pregnancy. But this is gravida 2. What's going on? How come she only has one live pregnancy? Where is the other one? She's currently pregnant. Okay? Does that make sense? So she's currently pregnant, and she had one preterm delivery with a live birth. Okay? So learning these codes, you get to learn a little bit about the woman herself right away. Okay? All right, let's do a few more. Okay, getting a little bit more complicated now. Here's gravida 2, para 1102. 1102. So, how many times has she been pregnant? 2 times. Okay? Did she have any full-term pregnancies? Yes. How many? 1. Good. Did she have any preterm pregnancies? Yes. How many? 1. Okay? Did she have any miscarriages or abortions? No. And how many live births has she had? 2. Okay? So she had a 1 full-term birth and 1 preterm birth. Both alive. Is that clear about that? Is she currently pregnant? No. Not by that code up there. Okay? So that's what's going on. So both children are living. That's what that last digit, that last digit 2 is telling us. Okay? All right, here's another one. Gravida 2, para 1011. How many times has she been pregnant? How many live children does she have? 1. Is that from a full-term pregnancy or a preterm? Full-term. Has she had any preterm pregnancies? No. Has she had any miscarriages or abortions? Yes. How many? 1. So here's somebody who's been pregnant twice. She had a full-term delivery with 1 live child, no preterm, and she had 1 miscarriage or abortion. Okay? So she had 1 full-term pregnancy with 1 abortion miscarriage. Again, with these codes, you wouldn't know if it's a miscarriage or abortion. Okay? Okay, so let's do this one. Gravida 3, para 1011. Looks similar, but not all of it. How many times has she been pregnant? 3 times. How many full-term deliveries has she had? 1. That's the first number here. How many miscarriages and abortions? 1. No preterm. And how many live children does she have? 1. All right? It's not hard. If you're getting to it, it's actually enjoyable once you get it, okay? It's not hard. So have 1 full-term birth and 1 abortion or miscarriage, okay? And she's currently pregnant, which I forgot to also mention. That's where you get the 3. So she's been pregnant 3 times. She had 1 full-term delivery, 1 miscarriage or abortion, and she's currently pregnant. That's giving her 3. Okay? Here you have Gravida 2, para 1000. Now we're getting a little bit saddened by looking at something like this. Saddened? Why? Okay. Here's a woman that's been pregnant 2 times. She had 1 full-term delivery. Now, where's the other one? Well, she's currently pregnant. That's what it is. Gravida 2. So she's currently pregnant, and she had 1 full-term delivery. How many living? None. All right? So that's what's happening here, is that one of her children have died. Okay? During the postnatal period. That's what we refer to. Okay? So that's what's going on here. She's currently pregnant. She had 1 full-term birth where the child died. Okay? And she's currently pregnant. What about this one? Gravida 1, para 1002. Did she have any miscarriages and abortions? No. Good. Is she currently pregnant? No, she is not. She did have 1 pregnancy. Was it full-term or preterm? Full-term. Did she have any preterm deliveries? No. How many live children does she have? 2. So how do you explain this one? She had a full-term delivery with 2 babies. You had twins. Okay? So do you understand how to do this? It's not a hard thing. Do make sure you just, have you and your, classmates just make up numbers and stuff and see if you can play games with them. Okay? It's not a hard thing to do, but you do have to speak the language. Okay? So this is 1 full-term birth with 2 living twins. Okay? Not bad. All right. So let's start talking about stages of labor. Okay. So here she's going through labor, and we have 3 stages where the baby and placenta and contractions all take place. All right. So here's the 3 stages. Stage 1 is when we have regular contractions. Now I'm going to abbreviate the word contractions because I'll be saying it quite often with CTX. So you're going to see CTX quite often. Even when you do your rotations, you're going to see CTX in the medical or maternity wards. So regular contractions, regular. So it can't be contractions. How far are they apart, the contractions? It's every 3 minutes, but then, it's going like 3 minutes, then it's going 5 minutes, then it's going 1 minute, then it's going 10 minutes. No, that's not regular contractions. Regular contractions is that it's constant. You could do it by the clock. Every 3 minutes, she's having contractions. Boom, boom, boom. And if they're getting shorter and shorter, she's going into labor. Okay? So we got to have regular contractions, not this big spacing. We have 3 minutes, and then it goes every 10 minutes, and every 20 minutes, and back to 10 minutes, then 15 minutes. Those aren't regular contractions. Regular contractions are enough to try and get a baby out of the womb. Okay? So when the time of regular contractions happening until the cervix, the opening to womb, is fully dilated, and we refer to the fully dilation as being 10 centimeters wide, the diameter of that cervix. Remember, it was a little pinhole to begin with, and then we're going to get it to about 10 centimeters, which is about that big. Okay? Stage 1 for a nulliparous woman, it's anywhere from 6 to 20 hours. It could take a long time for somebody who's never been through labor before. Someone who has been through labor before, who's given birth a number of times, at least 2 times before, once for that matter, it's going to be much shorter. So it could be anywhere from 2 to 12 hours. Okay? Stage 2 is when the cervix is fully dilated until the baby is completely out of the womb. Okay? In a nulliparous woman, takes about 2 hours to take place. In someone who's a multiparous woman, we're looking at 30 minutes to 1 hour or so. Again, it's going to be shorter. Then we have stage 3, which is really the birth of the placenta. So once the baby comes out, now we have to have time for the placenta, or they sometimes refer to it as the afterbirth, to come out. In a nulliparous, we go up to about an hour for that to come out. For multiparous, it takes up to 30 minutes. Now, these are up to 1 hour, up to 30 minutes. More likely it comes out in the first few minutes after childbirth, okay? But we do give it some time if it needs to be. So that's what those numbers are, okay? All right, postpartum period. We have to have, remember, keep in mind that uterus was this big when it had the baby inside, okay? So we're looking at the size of a watermelon. Then it needs to, once the baby and the placenta come out, now it shrinks down. But it won't go down to a non-pregnant state. That takes about 6 weeks to do. But it does shrink down, and it needs to shrink down because it stays that big. The muscle itself, remember the uterus is one big muscle, stays or remains boggy. When I mean boggy, soft. When it's soft, there's a lot of blood vessels there that were attached to the placenta. So those blood vessels are bleeding because the placenta was just delivered, so it's bleeding. We need to make sure that that uterus, what we say is involutes, it actually gets smaller and shrinks down to try and clamp down on all those open blood vessels, to compress them so that there isn't going to be bleeding. If that uterus stays boggy or soft, you're going to have massive bleeding, and we call it postpartum hemorrhage. We do not obviously want that. So we need to make sure that that uterus needs to shrink down to cut down on, or vasoconstrict those blood vessels that are in that uterus. Okay. Sometimes what we may have to do is massage the uterus. Once the placenta comes out, we massage that uterus, and the mother feels as though it's really painful. And it is, because the baby just came out of there. But when we massage it, that actually stimulates the uterus to contract. So that's what we're doing with that. Usually what we also do, too, is that we will inject Pitocin, which is the synthetic form of oxytocin. Going back to endocrinology, oxytocin is going to stimulate contractions of the uterus, right? So we can actually use it. It's called Pitocin, and we refer to the nurse and say we need to pit them. And when we say pit them, the synthetic form is called Pitocin. That's what we use, pit. And if you hear that in the maternity ward, that's what they're talking about. But really, what it is it's synthetic oxytocin to try and get that uterus to shrink down. Okay. The other thing that I and many doctors do, we ask the mother if the baby's fine coming out and is breathing and doesn't need to go to the NICU, which is the ICU for neonates, if the mother wants to start breastfeeding. I'm fine with that. I'm going to be working down below. If she wants to start breastfeeding, go for it. You know, you get that bonding, the mother-baby bonding as early as possible. But the other thing that you get is that during breastfeeding, nipple stimulation, that also sends a message to the uterus to contract. Okay, so that further stimulates oxytocin coming in from. Where does oxytocin usually come from in the? Well, where does it get secreted from? Normally in the human body. The pituitary gland. Good. Posterior or anterior pituitary? Posterior. So what happens is breastfeeding or nipple stimulation actually sends a message to the brain to go to the posterior pituitary, and it's going to secrete oxytocin. So we have different ways that we can actually try to involute that uterus so that we won't have postpartum hemorrhage. We can massage the uterus, which we do. We have Pitocin, which we do, and those things are the more common things. But it's up to the doctor, and of course the mother, if she wants to breastfeed. I have no problems with doing that. So again, that's what we try to do. But we need to get that uterus down to a small size, a shrink size. Now, and I'm telling you, a normal size of a uterus is about the size of maybe like a plum, right? That's a normal size. Maybe a double egg, so to say, egg and a half, right, if you want to think of that size. When we, just after pregnancy, just after delivery rather, the uterus will shrink down, involute, but it can't go down to that small. It's just been overly stretched, so it takes some time. But it will go down to a size of, maybe about the size of a mango, so about this big. But from a watermelon to a mango, eventually it's going to go to a plum. It's all fruit definitely. Okay. It takes about 6 to 8 weeks for the uterus of the woman to go into a non-pregnant state. So all the hormones. So what I'm saying is, even if you take a pregnancy test on a woman who just gave birth 3 weeks ago, the pregnancy test is still going to be positive because the hormones are still going around the patient's bloodstream. All right? It takes about 6 to 8 weeks for the uterus and the rest of the woman to become a non-pregnant state. Okay? So keep that in mind. Lochia. Lochia is normal residual blood that comes from the uterus. The placenta just came out. So there's going to be some residual blood that might just still be inside the uterus. We call that lochia. It'll probably have this bloody discharge, not heavy, and that's why we always got to check that after delivery. We need to make sure that it isn't heavy. But we're talking about a brownish or bloody, mucousy discharge that comes from the vagina, but it's really come from the uterus. It takes about a week or so before all that really goes away. Okay, but we call that lochia. Okay. We also have lactation. There's something called colostrum. Any of you heard about colostrum? Okay, good. Colostrum, it comes from the breast. This is actually the first milk flow that actually comes out in the first 3 days just after delivery. Now the lochia, the colostrum is the first milk that comes out. It's like a yellowish color, not the clear whitish color that you normally would see, but it's clear yellow color to it. This is highly rich in antibodies and proteins. This is like the best milk to give the baby. This colostrum, okay? So the question is, if mom is not too sure if she wants to breastfeed or not, I'm always encouraging her and talking with the lactation nurse who might have to need to come around to show how to have the baby latch onto the mother's nipple and answer any kind of questions. I'm always encouraging the mom, if you're not too sure, try it out now. Try it out in the first 3 days because you want to give that baby the most rich of all the milk at first. If you decide to do it, let's say a week later, you could do that, but you missed out on that window where you're giving the baby this rich milk of proteins and antibodies. So I'm always trying to encourage, not forcing her, but encourage that if she's on the borderline of doing it or not, I would say, why don't you try it out for the first couple of days, see if it works or not, see if you want to do that. Okay? So that's what that is. All right. Let's talk about twins. Twins, we could have identical twins or fraternal twins. What identical twins are, and I'll show you a picture of this. Identical twins is that one egg gets fertilized by one sperm. It's 1 and 1. Then you've got one cell, and that cell later on divides into 2. So it shares the same DNA as the sperm and the egg. Does that make sense? So during the morula stage, and you have to go back to the to your studies with the normal development of the embryo. But basically, this morula, which is what I refer to as a raspberry, kind of looks like a ball of cells inside and outside. But what happens is this morula and the inner cell mass of the morula actually will divide into two. All right, so it's sharing the same information, identical twins, and they are identical as you know, but they're not truly identical. They have the same kind of genes, and they share the same MHC class 1 and 2 proteins. So if you need, they have the same blood type. They have, if you need a kidney later on in life, you know, your identical twin sister or brother is the best person because it's sharing the same genes as you. But there are certain differences. For instance, their fingerprints are different. Okay, that can happen with that. So keep in mind that they are identical in so many ways, but there are certain things that will distinguish them from one person to another. Fingerprints is a good example. Fraternal twins is pretty easier to manage. Is that sometimes there's two eggs that ovulate, maybe from two different ovaries, or they could come from the same ovary. Either way, there's two eggs in the fallopian tubes this cycle around. When you have sperm that go there, and in one ejaculate, there's 300 million sperm. If there's two eggs there, they're going to have two sperms, two different sperms fertilizing those two different eggs. Okay, so that's what we're talking about. So each egg gets fertilized by two different sperms. So they're not identical in any way, except that they do share the same genes, but they are two different. There's still a mixture of genes there. Okay, still from the same mom, the same dad, but that's what's different with that. All right. So this is showing you about identical twins. So you have one sperm, one egg. It forms a zygote, but the inner cell mass of this morula splits into two, and because of that, you get identical twins. All right? In fraternal twins, what happens is two different eggs get fertilized from two different sperm, and you get two different, the inner cell mass is not going to split, okay? But what happens is you're going to get two babies born, growing in the womb.